Good afternoon, everyone, and welcome to another INNEG webinar. Thank you for joining us this afternoon. Today's session is part of the INNEG birth injury series of webinars, and we hope you enjoy it. We've run a few over the past months, and if you ever want to watch this recording or after the event or any of our other webinar series, you can get onto our website where all of the webinar recordings can be accessed. But today, just before we begin, I wanted to advise for those who haven't come across INNEG before, or perhaps haven't utilised our services before, we can support solicitors on the sourcing and the management of expert witnesses without any contractual basis. You're able to reach out to us just 2 or 3 times a year for those very tricky cases, either where you have a conflict with your go-to expert, someone's retired, or perhaps the subspecialism you're looking for isn't readily available within your team. So we have more than 13,000 members on our panel, in the INNEG panel. And so feel free to go onto our website to see the different types of experts we have, or alternatively, email our very helpful team who can advise you and provide you with suitable options. There's no contracts, and you can reach out on a very much an occasional basis. That aside, onto the main event. I'm delighted to welcome Dr. Kariholu to speak to us and to present to us today. Dr. Kariholu is a consultant neonatologist and obviously an expert witness. He's regularly instructed in a range of clinical negligence claims involving neonatal and birth injuries. He's been doing medico-legal work for quite a while now. I believe he began in 2018 and obviously focuses on a whole range of different cases within the neonatal space. He has an extensive experience both clinically and as an expert witness. And I'm delighted in a moment to welcome him to speak to you. Just before I do, please remember that we will have a Q&A session following, if time permits. Feel free to add any questions into the Q&A function, which you will see at the top. And just to let you know, the recording and the slides will be made available within the next couple of days following this webinar. So without further ado, Dr. Kariholu, thank you for joining us today. Over to you, please. Please continue.
Thanks, Leo. Good afternoon, everyone. Thank you, Leo, for the lovely introduction. I'm going to talk to you about neonatal failures and medico-legal risks in birth injury claims. Leo has already done my introduction. I must admit this is the first time I'm speaking in front of an audience with medico-legal background. My audience is usually from healthcare settings, so doctors, trainee doctors, nurses. So I've kept my slides very general, very generic to a large scale, and then towards the end there are a couple of specific case examples. As you're aware, we've got about an hour. Hopefully we should have 10 to 15 minutes for Q&A in the end. If you have any specific questions, I can try and address them. So just to start off with a bit of a background into medico-legal issues when it comes to neonatology. So neonatal medicine itself is a relatively new branch of medicine when we look at medicine as a whole. So maybe over the past 30 to 40 years, we've made huge advances in neonatal medicine. And in the past, decision making used to be assumed to be more of common sense. Now we know that decisions that are taken by us as neonatologists today are of huge sort of public importance. So we are taking decisions about a group of population who are going to be our future. And the difficulty there is that and our patients don't have any say in what we do. They can't participate in the decision making at the point. But obviously, when they grow up, the consequences of what we do. If things have not gone right, we would be open to questions in future. Decision making with regards to neonates is always, as you know, taken in sort of discussion with the parents. So any failures or any lapses in the management provided to newborns immediately after birth, usually in the first sort of few hours of birth when it comes to resuscitation, or sometimes during their course of neonatal intensive care admission, which is more relevant to preterm babies in the first sort of few weeks of life. Um, um, or, with regards to care which has uh, which has happened before a baby is born. So care of the mother during labor or pregnancy. So these are the cases that come forward. And my job in these situations is to look at the care of the newborn from the point they're born. Although I do factor in the history or management of labor, so events leading up to delivery, which helps me actually, sort of formulate a hypothesis or contribute to what I feel may have contributed to the injury as such. So there's a wide spectrum of sort of cases that come to my sort of desk, as it does to other medical legal experts. And from my experience, there's a vast range of issues which contribute to these errors, and they can be systemic issues, human errors, or simple deviation from standard protocols. And as you are all aware, with any sort of negligence, neonatal failure or negligence, these failures need to typically satisfy four elements. So one assumes duty of care. So a healthcare provider owes a duty of care to the mother and the baby. Number two, there has been a breach. So you have to show that the provider failed to meet the accepted medical standards or actually deviated from the medical standards. So i.e. breach of duty. And number three, that breach then led to or significantly contributed to the injury, which then has led to measurable harm. So you need to be able to fulfill these four elements of negligence, which would apply to adult population as well. Right, so let's just talk about common neonatal failures in birth injury claims, starting from the antenatal period. Now, the term perinatal means um, uh, that period which starts from the period of viability of a fetus or a baby when they're still inside mother's womb, up to the first few weeks of life. So the one of the commonest themes is delayed recognition or response to fetal compromise. Again, as I said, I'm a neonatologist. I look after newborn babies. I'm not an obstetrician, but the fetal neonatal medicine is a continuum in a way. So whatever happens before a baby is born has got implications on how what happens after they're born. So as a part of my job, it's my role and responsibility to look at the fetal well-being and the management before a baby is born. Although I'm not an expert, I'm not an obstetrician, I don't look after mothers, but it gives me a sense of what could have gone wrong before a baby is born. So this is one of the common themes that I come across. There's issues could be related to fetal monitoring as such. So CTG, as you know, cardiotocograph, which tells the obstetricians and midwives about fetal well-being by giving them an idea of fetal heart rate. So there can be issues with that monitoring. we know that interpretation of these CTGs can be tricky, so there can be individual variation in the interpretation, which then opens up margin for error and misclassification and delayed escalation as such. Now, in addition to issues with the interpretation of CTG or fetal well-being before a baby is born, there can be issues with the timing of delivery. So one aspect is either the obstetrician or the midwife not recognizing that something was wrong with the CTG. The other aspect is what did they do from that point, and were there any delays from the point any issues were identified with the CTG to the point of delivery? And there can be so many different factors contributing to that. In addition, anesthetics actually come in and have a role there. And was there any delay on their part to actually prepare the woman for delivery? So these two things go together. And inadequate monitoring or misinterpretation, I'm sure would then lead to all sorts of problems. Hypoxia is what we are worried about. And as a result, babies can suffer from hypoxic ischemic encephalopathy and brain damage, and which can be sort of on a milder end of spectrum without any long-term consequences, but equally on the most severe end, where the babies sometimes sadly don't survive, and if they survive, they have long-term neurodisability. The other common theme is mismanagement of shoulder dystocia, essentially, and the reasons being failure to anticipate the risk for shoulder dystocia, which could be related to either fetal malpresentation, the baby being in an awkward position, which would mean a lot of maneuvering needing to be for the baby to be delivered, or the baby being very large, which actually gets missed antenatally. And this can lead to birth injury, in addition to injuries like brachial plexus injury and Erb's palsy. Instrumental delivery, again, a major sort of area that claims are sort of associated with. Now, this could be because of excessive or prolonged or repeated attempts at the same sort of instrument. Now, there are different instruments that are used by the obstetricians in delivering babies, and some of them are forceps and kiwi, you may have heard of. So if an obstetrician actually, and RCOG, Royal College of Obstetricians, has clear guidelines on use of these instruments, and they've got certain criteria and guidelines which guide the clinicians. So these guidelines apply to which instrument for which sort of type of delivery, how many attempts are allowed, and if you're unable to deliver a baby after a certain number of attempts, what is the next step you need to think of? Do you need to go for C-section? Do you need to use an alternative instrument, and so on and so forth? So if sometimes these injuries can happen even if those guidelines are followed, but if those guidelines are not followed, and if someone actually perseveres with one particular type of instrument and has more than what is recommended number of attempts, or uses them not in the way they are supposed to, that increases the risk of birth injury. And the commonest sort of birth injuries encountered with these instruments would be bleeding inside the brain. So the risk of intracranial hemorrhage or bleed, as you can see, is 1 in 256 when both vacuum and forceps are used, as opposed to 1 in almost 600, 700 when only one of these instruments is used. Right. The other issue, particularly, I think, with when medical records were only paper-based, although all hospitals, had guidelines about saving and keeping these medical records in a secure place. But there were issues even with, say, for example, some of the results, investigation results missing. I believe since most hospitals have gone electronic, this is less of an issue. But still, for technical reasons, some of the results can be missing. Now, one of the studies actually has suggested that in about 38 to 40% of HIE, hypoxic ischemic encephalopathy cases, cord arterial gases were missing. And having paired cord arterial and venous gases is very critical for those of you who have encountered these cases in determining whether the hypoxia was chronic or acute. So without arterial gas, it becomes really impossible to actually say whether the duration of hypoxia essentially. And as you know, knowing how long the hypoxia actually went on for is one of the crucial elements, one of the most crucial questions that we need to answer. So if that arterial gas is missing, how do we actually comment on the management, and how do we then say that delivery should have happened at this time or that time? But we still come across these cases where gases are missing or placental histopathology is missing. So placental histopathology may provide you with that diagnostic clue about what went wrong before a baby was born. So this is an ongoing challenge, and even most recent cases that I've come across, some of this information is missing. Now, coming to the neonatal bit after the babies are born, which is where my area of expertise is, some of the claims that I've come across are in relation to delayed or improper resuscitation. So that can be because of staff being present who were not actually able to resuscitate or manage resuscitation appropriately because of lack of training, or adequately trained staff being present there, but for some reason they didn't follow the resuscitation guidelines. And the consequences are obviously hypoxia, ischemia related, multiple organ damage, neonatal death, sadly in some cases, and long-term cerebral palsy, neurodisability. Neonatal infection, I must say I have come across a small number of cases, but nevertheless I have reviewed some cases in relation to infection / meningitis. And again, the reasons being risk factors for infection not being identified in the mother herself. So things like maternal pyrexia or temperature or fever in a laboring mother, high infection markers in the laboring mother, and decision not to treat her with antibiotics. So as a consequence, you have a baby born who's potentially exposed to infection before they're born. And after they're born, for the team not to recognize those risk factors and not to actually start treat the baby with antibiotics, which then leads on to infection, full-blown infection, sadly meningitis in some cases, and some of these babies don't survive. Again, inadequate monitoring of babies. Again, less number of cases, but sometimes you do come across these cases where babies on neonatal intensive care unit were not monitored as well as they should have been. Right, communication and cover-up consent and cover-up perceptions. One of the major things that comes across from many of these claims is this perception that the hospital is trying to hide something. Often when things don't go right, the natural sort of instinct of many patients is that we are not, we felt that we were not being heard, or when we asked the questions, we didn't get the right answers, which makes them feel and believe that the hospital is trying to cover up. They're trying to hide their mistakes. They're trying to protect their colleagues. Plus, one of the studies, again, you can look at the reasons people gave for pursuing medical legal claims was also, for some of those parents being advised by others. So, they're often it's family members, extended family members. And this data is, as I've said in my slide, is very interesting because it does show that these claims are often driven by sort of process and relationship failures rather than by actual sort of technical error as such. Now, some other cases may be related to delayed or incorrect diagnosis, like hypoglycemia, infections. Hypoglycemia essentially means low blood sugar levels, infections, which we've talked about previously, improper treatment or interventions. Again, in a baby who's had extensive resuscitation, for local teams not to then think about cooling treatment, which is the only treatment which is proven to be of benefit in babies with hypoxia, birth asphyxia. Right. Okay. So that was a whiz through some of the common sort of scenarios, maybe some specific neonatal situations in the next few slides. I know I've said that we will address some questions towards the end. I hope that's still okay, but please, make a note of any doubts, any questions that come to your mind as I'm going through these slides quickly. So neonatal resuscitation is one of those stressful scenarios where both starting resuscitation and stopping resuscitation needs a huge amount of experience. Starting not so much, but stopping definitely. Now, cases where babies have needed extensive resuscitation and haven't actually responded appropriately or as expected, the decision to stop resuscitation has to be taken very carefully. Often it's taken in sort of conjunction with your team involved with resuscitation, with a more senior sort of input. Now, with regards to resuscitation, as I said, failure to follow NLS guidelines, NLS UK guidelines is what we would look at when we are looking at breach of duty. Did we start resuscitation at time? Was there any delay in starting resuscitation? Say, for instance, a baby is born in a poorly condition. Was there any delay in putting out the crash call? So at what time was the baby born and at what time was the resuscitation started? So those few minutes can make a huge difference. And when the team arrived, did they follow those NLS guidelines? And one of the areas where often things can go wrong is their airway management. When you're trying to open up and inflate a baby's lungs, a baby who's not breathing. Then the key areas there would be ensuring that the air is open and you are still able to move the chest when you're trying to do other things. Now, for instance, some of the cases that I have come across, a doctor, for example, has sort of tried to attempt intubating a baby on multiple times, and intubation is a technical skill and that comes with experience, but some of these babies have what we call a difficult airway. So if a doctor then tries to intubate the baby despite the attempts not being successful and then tries to persevere with those and completely ignores the fact that the baby is remaining hypoxic through that period, that would amount to breach of care, as opposed to that doctor recognizing, okay, fine, I've tried once or twice and I can't intubate the baby. Let me just try to manage the airway safely with a face mask. At least try to oxygenate the baby. So not being able to intubate is not breach of care, even if you're an experienced clinician, because we know that some babies don't have the anatomy as it should be, but actually failing to recognize the fact that you're in the process of trying to intubate the baby, making the baby hypoxic. Then early neonatal encephalopathy, similar sort of linking in with the same scenario, babies who need resuscitation at birth, who are born in a very poorly condition, who've had birth asphyxia. The question often with these cases is not whether a baby has suffered from neonatal encephalopathy or birth asphyxia. That's usually clear cut. The questions often asked are, could something have been done to have prevented this? So the scrutiny then there is to the care leading up to delivery. As I said, minutes actually can make a huge difference. So were there any signs that could have been acted upon before the baby was born? That could have been the CTG, fetal heart monitoring, passage of meconium, say for instance, signs of infection in the mother before the baby was born. So could the delivery have been expedited? Could they have gone for C-section earlier? So all those things get reviewed, and again, once the baby is born, you look at the baby's condition after birth, extent of resuscitation needed, and was everything done in line with NLS recommendations. As I said in one of my earlier slides, babies who are born with birth asphyxia or HIE, the only proven treatment which can help them long term is cooling. So wherein we reduce their temperature down to 33.5 degrees Celsius. Normal temperature, as you know, is 36.5 to 37.5. In cooling treatment, we bring their whole body temperature down to 33.5 degrees. So that's the only treatment that we know for sure works in reducing the impact of hypoxia on their brain. So did we start that treatment on time? And there is a window, so there's a 6-hour window to start that treatment. Did that happen on time? Did it not happen at all? Again, something that I always say to my medical colleagues and trainee doctors is that in these cases, notes need to be very thorough, careful, contemporaneous, and written in a non-judgment manner. Often in neonatal encephalopathy cases, or cases that present as neonatal encephalopathy or birth asphyxia to start off with, and in these situations where the child then develops cerebral palsy or neurodisability, my role is also to make sure that there is no other pathology that explains the baby's condition at birth, because some other genetic and metabolic conditions can present as birth asphyxia. So that's something that comes out when we review that period of delivery and management of labor as such. And sometimes we do need to involve other specialists, neurologists, geneticists, and they can be of immense help. Right. So preterm brain injury, this is one of the most difficult areas that I sort of personally feel. Because with prematurity, the risk of neurodisability is high anyway. And the more premature you are, the higher the risk of neurodisability. Then when I see a case of a child with some form of neurodisability, and they were born prematurely, it becomes very difficult for us as medical legal experts to then say that this neurodisability is solely linked to some event that the parents were worried about, because being born premature itself increases the risk a lot. So they can be really tricky in my experience, unless there are some clear cut sort of events during that baby's care which explain the changes in relation to their development. I've mentioned hypocarbia, which means low carbon dioxide levels in their blood. This is one of those situations which clearly leads to a reduction in oxygen sort of supply to the brain, and it can lead to the formation of holes in a baby's brain. So some specific situations are easy, but on the whole, if there's nothing else in that premature baby's history, which is uncommon, unusual for a preterm baby, it becomes very tricky to actually be 100% sure. So neonatal jaundice that leads to kernicterus. So kernicterus is luckily very rare these days. It used to be more common maybe 10, 15 years ago. This is a condition where the bilirubin levels, bilirubin is the yellow chemical present in our blood, which gives yellow discoloration to the skin, which is commonly known as jaundice. So newborn jaundice is very common for physiological reasons. But in a very, very small number of babies, the level of the jaundice levels, i.e. bilirubin levels, are so high that they cross blood-brain barrier and then cause damage to the brain. And many of these babies then develop cerebral palsy in the long term. The risk has slightly increased, although I've said, as I said, that the numbers have gone down, but the risk had slightly increased in the recent years with the drive to discharge mothers home early. So we used to have, most of these mothers after delivery used to be kept in the hospital for good 24 hours, 48 hours. But then there was a drive to 6 hours, discharging them soon after 6 hours. So 6-hour discharges had become common. And with that came the potential risk of missing a baby with jaundice. So because they would be at home and so to pick up jaundice early on in the first 24, 48 hours was becoming very difficult. But I think, in most areas where we do have good community midwifery service available, the pickup rate is very good. Although, every now and then we do come across babies with very, very high levels of jaundice, luckily not causing kernicterus. Hypoglycemia, low blood sugar levels. Again, in my experience, many claims are not successful because many of them are in relation to very sort of one-off or a couple of periods of episodes of hypoglycemia. And although we do have brain MRI changes which are linked to hypoglycemia, they are not very sort of they're not pathognomic for hypoglycemia as such. So other conditions can also present with those MRI changes. So you have to be, really certain that hypoglycemia was, particularly prolonged symptomatic hypoglycemia, was solely responsible for what you are actually encountering clinically. So retinopathy of prematurity, again, a small number of cases, but something that can come to our desks as medico-legal group of medico-legal experts. So retinopathy of prematurity is a condition, as you can see from the name itself, seen exclusively in premature babies who are exposed to oxygen. So high levels of oxygen or ventilation can stimulate development of blood vessels at the back of their eyes, which can then lead to varying degrees of visual impairment, even leading to detachment, retinal detachment, and blindness. Now, oxygen is a very important drug necessary in this group of vulnerable babies. And we have strict guidelines with regards to what oxygen levels you should be aiming for in premature babies based on different various studies. So there's a balance, giving too much of oxygen can cause ROP or retinopathy of prematurity, and giving them too little oxygen and keeping their oxygen saturation levels low could lead to death. So there's a balance of where you want their oxygen levels to be. And based on various studies, we think we found that sort of number which works for premature babies. So that would be under scrutiny whether a baby was given excessive oxygen or whether a baby baby's oxygen saturations were in the low range. But usually more than that, it is the screening side of it which comes under scrutiny. So this group of babies, because of the risk of ROP, are supposed to have ophthalmology review done at regular intervals. There are guidelines for different gestational age group babies. So often it comes out from these case reviews that those reviews by the ophthalmologists didn't happen in a timely manner, or if and once they find any abnormalities, they were not acted upon because the baby was too unwell or baby was too sick. So say, for instance, some of these extreme stages of ROP need surgery, laser surgery, and the baby is extremely unwell at that point, and the decision then is to defer the surgery by a few days or a week or two. And by the time the surgery is done, it's already too late. So if that's the case, was there an informed decision sort of taken? Were the parents involved? Were they informed of the risks versus benefits of waiting at that time? So all those things need to be factored in when reviewing these cases. Deafness. I've come across maybe one or two cases of deafness where a baby was exposed to an ototoxic medicine. Aminoglycosides are the most common used antibiotics in the newborn period, which can lead to deafness. But remember, most of this is genetic in origin. Again, proving an association can be tricky. Often, audiology experts and ENT, ear, nose, throat experts need to be involved. We've talked about infections previously. Now, missed abnormalities on the newborn infant physical examination, NIPE examination, can also present to us. Now, as a part of the newborn screening in the UK, all newborn babies are supposed to have a head-to-toe examination done in the first 72 hours of life. But we know that this examination is not perfect, i.e. some of these conditions may not be obvious immediately at birth, especially conditions related to heart or eyes, and as a result can be missed or may not be picked up on the initial assessment and then present later on. So I've come across at least 2 to 3 cases of DDH, or developmental dysplasia of the hip, wherein the hip joint is not formed as it should be, and then it later on leads to difficulties with walking and all sorts of issues with the back. Biochemical screening, again, newborns have a heel prick test done when they're about a week old, 5 to 7 days old, and this is essentially to look at a range of metabolic conditions which can be treated. Sometimes there can be an issue with these not having been done, or the sample being misplaced, or the results being sort of misplaced. So this is something that we do encounter at times. Scarring in the neonatal population usually is not, as I've said in my slide, is usually not disfiguring because our procedures are not that invasive generally, but sometimes they can lead to contractures or cosmetic problem if there's a scar on the face. I think I've maybe seen only one such case in my experience. In addition, sometimes complications due to lines and extravasation can lead to cardiac tamponade or even paraplegia. Vitamin K deficiency, again, one of the very hot topics when it comes to practicing medicine. Some of you may be aware that vitamin K injections have been linked to autism. If you Google, you'll find so many different articles. But from a doctor's perspective, I can say that there is no evidence this causes autism. But it's out there in the media, it's out there in the press. So many parents refuse vitamin K injections at birth. And we know that babies are born vitamin K deficient. So human babies produce vitamin K after some time, a few weeks down the line. So if we don't give vitamin K, the risk of bleeding increases. Vitamin K is absolutely essential in forming those factors which form a clot if there's a cut or a bleed. Now, the risk of bleeding inside the brain is much higher in premature babies. So if the parents refuse, that needs to be documented. But if a baby is very unwell, we'll come to consent bit as well in the next few slides. As doctors, we're obliged to do what is best for the babies, particularly the ones who are in intensive care. We would normally give it, document it, and obviously have that discussion with the parents. Right, I'm just mindful of the time. So we'll just go through consent and special circumstances. So consent, as you know, anyone with capacity to take decision can give consent or refuse consent. Same principles apply to babies, but babies can't speak, they can't give consent, so that decision lies with or rests with the parents. But obviously, parental duty and responsibilities to act in the baby's best interests as well, and that's where sometimes that conflict can happen between the healthcare professionals and the parents. So who's able to give consent? Single mothers can give consent. Either parent can give consent provided they're married or the father has acquired parental responsibility. Very young, competent mothers can give consent, but often you see that the family grandparents are often involved. If there's a social care team involved with any social background, they are often involved in the decision making. And mothers with psychiatric illness, we often involve the psychiatrist and the obstetric team when we talk about sort of any procedures as such. Now, if the parents disagree, if both of the parents are on sort of have the right to give consent and they disagree, very unusual situation. I must say that in my experience, I've not come across this. Um, but if they do disagree, hopefully, in most cases, we should be able to address this by just communicating with them and speaking to them and trying to address their reasons for accepting or refusing whatever treatment is being suggested. But if we can't come to an agreement, then obviously legal route is the only option. Again, something important with consent is that it is a healthcare professional's duty to make sure that the parents understand the benefits of a treatment or a procedure, and also the potential risks and consequences of not actually undergoing a treatment or a procedure. So that's what we call informed consent. So you cannot just go and speak to the parents without explaining the pros and cons of whatever you're recommending. And that needs to be documented in the notes. As I said, refusal of treatment, parents refusing treatment is less common, although in the neonatal age group, particularly with extremely premature babies, we are now, as a group of neonatal intensivists, coming across more and more parents who are sort of because of information available on ChatGPT and Dr. Google, questioning a lot of decision making, which may not be in their baby's best interests. But in my experience, again, most of this can be addressed by open and honest communication with them. Giving them as much information as needed to help address their queries. Sometimes, I think it's on my next slide, more relevant to discontinuation of futile treatment involving religious priests does help, involving clinicians from another hospital. So second opinion is often helpful in these situations. And very, very, very rarely do we need to go to the court and seek formal legal opinion. And in my experience at Imperial, over the past sort of 10 years or so, there's only one occasion where we've had to take formal legal opinion and had to actually go to the court, and that happened only about 3 months ago. So it's very, very, very unusual for us to go to that extent. But it does happen sometimes.